Welcome, focus learners, to this high-yield medical explainer on the anatomy of the heart. Whether you're prepping for your first-year medical exams, your nursing boards, or you just really need to master cardiovascular anatomy, you are in the right place. This session is designed specifically to give you the structured clarity you need. We're going to strip away the fluff and focus directly on the core anatomy that dictates function, survival, and your future clinical practice. Let's get started. Here's our roadmap for today's explainer. We'll start with the double pump concept, move into chambers and mechanics, tackle the extremely important coronary infrastructure, cover venous drainage, and finally, wrap up with applied clinical anatomy.
All right, kicking things off with Section 1, the double pump, from macro to micro. Anatomically speaking, the heart is a pyramidal, or kind of conical organ situated right in your thorax. And what's truly fascinating here is its efficiency compared to its size. It's surprisingly compact, literally just a little bit larger than your own clenched fist. It weighs in at roughly 300 grams in males and 250 grams in females. It's honestly astonishing to think that this relatively small bundle of muscle beats roughly 100,000 times a day, continuously driving blood through miles of your body's vascular network from the very moment you're born. This beautifully illustrates the functional anatomy of the heart as two distinct yet perfectly synchronized pumps. The right side of the heart is in charge of pulmonary circulation, pushing deoxygenated blood right into the lungs. Because your lungs offer relatively low resistance, the right ventricle's muscular wall doesn't need to be overwhelmingly thick. But contrast that with the left pump. That left ventricle has to drive oxygenated blood through your entire systemic circulation. We're talking from the top of your head all the way down to your toes. To overcome that massive high-resistance peripheral network, the left ventricle's myocardial wall has to be much, much thicker than the right.
Moving right along to Section 2, Chambers and Mechanics, looking inside the pump.
Let's crack open the right atrium, which receives systemic venous blood. Now, a classic, absolutely high-yield exam point to note here is the right atrium's dual topography. Notice how the interior is basically divided into two distinct parts. You've got the posterior part, which is perfectly smooth. That's the sinus venarum. Then, the interior part is rough and muscular. That's the atrium proper. Internally, these two distinct sections are separated by a muscular ridge known as the crista terminalis. Externally, this exact dividing line corresponds to a shallow groove called the sulcus terminalis. Definitely memorize those boundaries because they show up on exams all the time.
Now this is where it gets really cool mechanically, the setup of the atrioventricular or AV valves. You have the tricuspid valve on the right side and the bicuspid or mitral valve on the left. During a really powerful ventricular contraction, also known as systole, the pressure inside those ventricles absolutely skyrockets. So to prevent the valve cusps from blowing entirely backward into the atria, kind of like an umbrella flipping inside out in a massive windstorm, they rely on this brilliant anatomical tethering system. They're connected to strong papillary muscles that project from the ventricular wall, and they are held there by tough, fibrous cords called chordae tendineae. You can think of them exactly like parachute strings holding the valve perfectly taut.
We can immediately tie this elegant anatomy straight to a severe clinical scenario. Imagine a patient suffers a heart attack or myocardial infarction that starves a papillary muscle of oxygen. That muscle can literally die and rupture. Suddenly, those parachute strings just detach. The AV valve immediately prolapses into the atrium during the very next beat, which leads to massive, catastrophic blood regurgitation. This causes sudden, severe, acute cardiac failure. It's a perfect example of how structure absolutely dictates survival. Contrast that whole system with the semilunar valves located at the exits of the ventricles, meaning the pulmonary and aortic valves. Notice the complete lack of parachute strings. There are zero chordae tendineae and no papillary muscles here. Instead, these valves rely entirely on the precise geometric fit of their three half-moon-shaped cusps, plus the structural integrity of the vessel walls. They just snap shut perfectly to prevent regurgitation as blood tries to fall back into the ventricles during diastole.
All right, let's dive into Section 3, the coronary infrastructure, which is all about the arterial blood supply.
Your heart muscle works incredibly hard, but it can't just absorb oxygen from the blood inside its own chambers. The walls are simply too thick for that, so it needs its own dedicated plumbing.
Functioning essentially as the vasa vasorum of the ascending aorta, the right and left coronary arteries pop right out of the base of the aorta, just above the aortic valve cusps. Specifically, the right coronary artery arises from the anterior aortic sinus, the left coronary artery arises from the left posterior aortic sinus, and that leaves the posterior aortic sinus completely empty, naturally earning it the name the non-coronary sinus. Listen up closely to this next concept, because coronary dominance is a massive, high-yield exam topic. When we say a heart is right dominant or left dominant, we are not talking about which artery is physically larger or which one supplies more overall mass. No. Coronary dominance is determined strictly by one specific anatomical landmark. Which artery gives rise to the posterior interventricular artery? In about 90% of individuals, the right coronary artery wraps around to the back of the heart and gives off this branch, making them right dominant. In the remaining 10% of people, it comes off the circumflex branch of the left coronary artery, making them left dominant.
Section 4 already? Let's talk about venous drainage and returning the blood.
Since what flows in must eventually flow out, most of the heart's venous blood pools into a massive vessel sitting in the posterior atrioventricular groove. This is called the coronary sinus, and it dumps directly into the right atrium. It's fed by major tributaries that basically shadow the arteries. So the great cardiac vein runs alongside the anterior interventricular artery. The middle cardiac vein runs with the posterior interventricular artery, and the small cardiac vein accompanies the right marginal artery. Oh, and don't forget the tiny Thebesian veins. These are super unique because instead of routing all the way back to the coronary sinus, they just drain directly into all four of the heart's respective chambers.
Finally, we've reached Section 5, Applied Clinical Anatomy, where we see what happens when the infrastructure fails.
Distinguishing between these two incredibly common cardiac presentations is absolute gold for your exams. Angina pectoris is caused by a narrowing of a coronary artery. It results in reversible ischemia, meaning the tissue is temporarily starved of oxygen. This is usually triggered by exertion when the heart is forced to beat faster, but crucially, the pain goes away with rest. A myocardial infarction, or an MI, is a totally different story. It's a complete block of the artery, leading to irreversible tissue death, also known as myocardial necrosis. Because the blockage is absolute, an MI can happen entirely at rest and is always a dire medical emergency.
If we look at the actual statistics of where these critical blocks happen, the breakdown is pretty eye-opening. The anterior interventricular artery, which is almost always called the left anterior descending, or LAD in the clinic, is the main culprit nearly half the time, roughly 45%. Next is the right coronary artery at around 35%, followed by the circumflex branch at the left coronary artery at 18%. Because the LAD supplies a massive portion of the powerful left ventricle, a blockage here is famously dangerous. In fact, it's so dangerous it's earned the notorious clinical nickname, the Widowmaker.
So, how do we fix these blockages? First, cardiologists perform coronary angiography. They inject a contrast dye to literally light up the exact site of the blockage on an X-ray. If they can, they'll perform an angioplasty. They feed a tiny, deflated balloon right into the blocked artery, inflate it to crush the plaque against the walls, and then leave a wire mesh stent behind to hold it open. But if the blockages are too severe or there are just too many of them, surgeons step in to perform a CABG, that's coronary artery bypass grafting. They essentially build a detour. They take a healthy vessel like the great saphenous vein from the leg or the internal mammary artery from the chest, and they sew it from the aorta directly to the coronary artery, completely bypassing the blocked segment.
Ultimately, as you progress into the clinic and grab your stethoscope, everything you evaluate is fundamentally grounded in this precise structural anatomy we've been talking about. When you listen to that classic, rhythmic lub-dub, you are physically hearing those AV and semilunar valves snapping shut. When you hear a whooshing murmur, you're mentally visualizing the turbulent blood flow caused by a stenosed valve, or maybe a prolapsing cusp that's missing its chordae tendineae. Your clinical diagnostic skills rely entirely on how well you can visualize the internal mechanics of this double pump.
And with that, I'm going to leave you with one final, high-yield exam question to really test your attention of today's explainer. Think carefully. If a patient's LAD artery is completely occluded and you trace it all the way back up the arterial tree, from which exact aortic sinus did that interrupted blood supply originate? Think about the sequence we just built together. Connecting these fundamental anatomic pathways is exactly what transforms a student into a brilliant clinician. Figure out the answer, trust the structure, and keep learning.